My name is Rodia Shudunke. Good morning, everyone. My name is Rodia Shudunke. Welcome to another episode of the YOF lecture series. And today, Dr. Chinedu Ugo from Eye Foundation Hospital would be taking us on minimally invasive glaucoma surgeries. So if you have any questions, comments, contributions, clarifications, you can leave them in the chat box and we'll get to it as soon as we can. So it's already 9:03. We have about 25 participants. I'm sure others will want to join, but we can start now. Okay, Dr. Ugo, you have the floor.
All right. Good morning, colleagues. I'll be presenting minimally invasive glaucoma surgery. So I'll be doing that under the following outline. So by way of introduction, glaucoma is the leading cause of irreversible blindness globally. It's been estimated that by 2040, about 111.8 million people will have glaucoma. And the intraocular pressure is the only modifiable risk factor. So lowering intraocular pressure is still the mainstay of treatment till date. Traditionally, topical medication, lasers, and incisional surgeries have been the primary means to lower intraocular pressure and treat glaucoma. Medications require that patients should be adherent and instill the eye drops properly. The effectiveness of laser decreases over time, and trabeculectomy and tube shunt surgeries are very effective but carry significant risk and complications. So as an alternative to traditional glaucoma medication, glaucoma treatment, minimally invasive glaucoma surgeries has shown promise for the future management of glaucoma. And it's also important to note that minimally invasive glaucoma surgeries, which I'll be using as Migs for short, are typically combined with phacoemulsification. It doesn't mean that it cannot be done alone, it can be done alone. So while the long-term results are being awaited, it's said that Migs have revolutionized glaucoma management with minimal tissue trauma, good operative recovery, and improved patient satisfaction. So to define Migs, there are 5 characteristics of Migs. One is that it's high.
Sorry to cut you short. Sorry, Dr. Ugo. I was trying not to interrupt you. Your slides are not moving. It's still on outline.
Oh, really?
So it's still on slide 2.
Is it moving now?
Okay, but it's on slide 2 now, but it moved. Okay, it's on slide 3 now.
Okay, I think I'll just leave. If I put on slideshow, it doesn't move, I guess. So I'll just leave it on the window here. So
okay.
So I'm done with the introduction. So this is where I am now. Can you see Migs definition?
Yes.
Okay. So there are 5 characteristics of Migs. In trying to define Migs, these are the things we look at. The high safety profile must have a high safety profile. So you should have much lower risk of serious complications. There should be minimal trauma, so destruction of normal anatomy and physiology. And then also, it should be implanted through, or the surgery should be an internal approach. So that's through the clear cornea into the angle. Then it should have good efficacy, in the sense that IOP reduction should be at least 20%. And then it should be there should be ease of use for patient and physician. In the side of patient, rapid post-op recovery with minimal need for follow-up. And in the side of surgeon, the surgery should be easy to perform. And it should be typically easily incorporated with phacoemulsification surgery. So what are the indications? Migs are indicated in mild to moderate glaucoma cases, primary open-angle glaucoma, pigmentary and pseudoexfoliative glaucoma, intraocular pressure. When intraocular pressure is not reduced, even if after maximal glaucoma therapy or laser trabeculoplasty, when the patient is non-adherent to medication and all efforts to improve adherence has proved abortive. And then also when there is adverse reaction to topical glaucoma medication. So what are the contraindications? When there is active neovascular glaucoma, primary angle closure glaucoma or secondary angle closure glaucoma, cornea opacities, because we need cornea clarity to be able to do the surgery. When there is angle dysgenesis, because you need a proper anatomy, a well-formed anatomy to be able to identify the structures when you are doing the surgery. And then if there's elevated episcleral venous pressure, as some of these surgeries are dependent on the egress of fluid through the Schlemm canal, or rather through the Schlemm canal into the episcleral vein. So we will classify the Migs. So basically, the Migs are classified into four basic groups. So the first group are the surgeries that increase aqueous outflow from trabecular meshwork and Schlemm canal. So in other words, some of them bypass the trabecular meshwork into the.
Hello, Dr. Ugo.
Yeah.
I can't hear you.
You can't hear me? Hello, can you hear me now?
Yes, I can hear you now.
Okay. So please, at any time you don't hear me, please let me know. Okay, so I said there are, in the classification of Migs, there are four groups. The first group, which I believe you can see on the slide now. Can you see number one, increasing aqueous outflow from trabecular meshwork and Schlemm canal?
Yes, we can see.
Okay, good. So these include the stents, those that involve implanting stents, those that involve tissue removal, and those that involve increasing outflow through the Schlemm canal. So the stents, the eye stent inject, hydros, then the one that involves tissue removal, gonioscopy assisted transluminal trabeculectomy, Cahook, dual blade goniotomy, trabectome, Trab 360 system, excimer laser trabeculostomy, Visco 360 device, and add internal canaloplasty. So we'll take each of them one by one. So the eye stent, this is a picture of an eye stent. It's an L-shaped device that is implanted into the Schlemm canal with the opening into the anterior chamber. So we can see the aqueous flow stream through. Can you see my cursor?
Yes, we can see your cursor.
Aqueous flows in through here. This is the part that fits into the Schlemm canal. So as aqueous flows in, it goes in. This also helps to maintain the Schlemm canal. So this is a picture of it as implanted into the Schlemm canal with the opening into the anterior chamber. So this device, the studies that have been done is injected actually into the anterior chamber with a device that is already preloaded. So the body of the device, like I said, resides in the Schlemm canal. A study, that's the clinical trial to assess the efficacy of this eye stent was done, and 68% of the patients who received eye stent placement at the time of cataract surgery were medication free at 12 months. Were medication free at 12 months with intraocular pressure of less than 21. That's after the implant. So there was no serious complication that was associated with eye stent, and most common complication was stent obstruction and malposition, and neither of them caused any adverse event. Multiple eye stents can be safely implanted and result in effective intraocular pressure reduction and fewer glaucoma medications. So the second generation eye stents, these two are actually produced by glucose company. So the eye stent inject is the second generation. So this is smaller, and this is what we use the device for injecting it. So it's preloaded into this device and injected. So the picture you can see here are the pictures the eye stent inject in the anterior chamber. So this bypasses the trabecular meshwork. So this end is inside the Schlemm canal, while this end is inside the anterior chamber. So this device, the clinical trial, about 75.8% of patients who underwent eye stent inject with phaco experienced greater than 20% reduction in intraocular pressure, compared to 61.9% in phaco alone group. So the patients in eye stent phaco group had a mean IOP reduction of 7 plus or minus 4 millimeters of mercury, compared to 5.4 plus or minus 3.7 millimeters of mercury in phaco group only. And 84% of the eyes that combined phaco with eye stent were medication free at 23 months, compared to 67% of eyes that had only phaco. The third example of the stent is the hydrous micro stent. So as you can see, this is a crescent-shaped device. This end is the inlet, which is in the anterior chamber, while this is in the Schlemm canal. So it's implanted in such a way that the inlet allows aqueous to flow through. So it bypasses the trabecular meshwork and allows aqueous to flow through this inlet into the Schlemm canal. And also this helps to maintain the Schlemm canal as it starts as a scaffold to maintain the Schlemm canal. Please, can you all hear me?
Yes.
Yes.
Okay.
Yes.
All right. So this in the clinical trial called the Horizon study that was done to assess the efficacy of this hydrous microstent. Dr. Shorinke.
Yes.
Dr. Shorinke, please, when I've spent 20 minutes, let me know.
Okay.
Thank you.
All right.
So the Horizon study, in this study, 7% of eyes that had hydrous with phaco had a greater than or equal to 20% reduction in the intraocular pressure, compared to 57.8% who had phaco alone. So the hydrous phaco group went from 1.7 plus or minus 0.9 drops to 0.3 plus or minus 0.8 drops at 24 months. So there was a significant reduction in the use of eye drop in the phaco hydrous group compared to phaco alone group. So remember, we started with we classified the first group, which are the groups that try to bypass the anterior chamber, the trabecular meshwork and channel aqueous into the Schlemm canal. Now, the first one was the stents, which we mentioned. The second one are the surgeries that involve removing or creating a direct access into the Schlemm canal. Now, the first example is the Cahook dual blade goniotomy. Now, this is a double-edged blade that is able to excise the whole of trabecular meshwork. So it can be done up to 180 degrees or more. So it's used to excise the trabecular meshwork such that after excision, you're able to see the Schlemm canal as the white hue, as you can see in this picture. You're able to, the white picture here, the white line here is the Schlemm canal. That's after the trabecular meshwork has been excised. So it's a single-use device, and you can excise up to 180 or more. Now, in the clinical outcome, 52 eyes were used. There were actually a lot of studies that were done on this. 52 eyes of patients with open-angle glaucoma underwent cataract surgery with Cahook dual blade goniotomy. And at 1 year, the intraocular pressure it achieved about 26.2 reduction in the intraocular pressure. So about 57% of the eyes actually experienced greater than 20 or greater than or equal to 20% reduction in intraocular pressure. And there was also a significant reduction in the number of eye drops from 1.6 plus or minus 0.2 to 0.8 plus or minus 0.1 at 1 year. So the next one is the trabectome. Now, the trabectome uses a combination of irrigation, aspiration, and electrocautery to remove the trabecular meshwork and the inner wall of the Schlemm canal. This is the device that it uses. So it has a pedal which for the control of this device. So this is actually the electrode through which you do the irrigation, aspiration, and electrocautery. So this is the probe trying to remove the trabecular meshwork alongside the inner wall of the Schlemm canal. And after it's been removed, you can see the openings of the Schlemm canal, the collecting ducts through the in the Schlemm canal. So it's in the study to assess the efficacy of this device, about 80 eyes, sorry for that typo, of 69 patients underwent standalone trabectome, and the intraocular pressure decreased from 26.6 plus or minus 8.1 to 17.4 plus or minus 3.4 millimeters of mercury at 6 months. So the average number of medication also decreased from 4 plus or minus 1.4 to 2.3 plus or minus 1.2 drops at 6 months. There was also another study that studied 304 eyes of patients with open-angle glaucoma, combined with trabectome combined with phacoemulsification, and the mean IOP reduced from 20 to 15 at 1 year post-op. So the complication of this surgery include iris injury, was highly reduced injury in 4 patients, and the IOP spiked in 26 patients. The fourth one is the goniotomy-assisted transluminal trabeculotomy. Now, this involves using an eye catheter, which is an illuminated catheter at its tip, or a Prolene suture. So first, a goniotomy is made into the Schlemm canal through the trabecular meshwork, and this suture or the catheter is passed through the Schlemm canal round. So one end is outside. This is the end that is outside. Then this end, this one that is here now, was passed through here and came out through this end. So in the process, after it has come out from the point of entry, the surgeon now pulls the tube, the catheter or the Prolene suture out, now creating a communication between the anterior chamber to the Schlemm canal. I actually tried to make a video, but I'm not sure there's time to watch how it's done. So we can do that on our own. Okay, but the surgical technique, like I said, I described. So it's a 360 trabeculotomy with the catheter or the Prolene suture. So the clinical study to assess the outcome in some of the patients that underwent this surgery. There were about 85 eyes of 85 patients included in one of the study, and 57 patients, 57 of them had primary open angle glaucoma with an IOP reduction of 11.1 plus or minus 6.1 after the surgery, and their eye drop reduced. They required a 1.1 of fewer eye drops at 1 year post-op. So there was a significant reduction in their intraocular pressure and the number of drops required 1 month post-op. So for the 28 patients so the initial one I mentioned was 57 patients out of the 85 eyes. So now the remaining 28 patients with other forms of open angle glaucoma had an average IOP reduction of 19.9 plus or minus 10.2 millimeters of mercury. And the patient required a 1.9 fewer eye drops at 1 year post-op. And the most common complication was transient hyphema that was reported in 30% of patients at 1 week post-op. And then by 1 month, this was resolved. The next one is TRAP 360, which involves a device, as you can see, that has a sharp edge through which goniotomy is made into the Schlemm canal, and a catheter, which is already, a suture, which is already loaded into this device, is advanced through this wheel to the Schlemm canal at just 180. Initially, it's done, you do the first 180. So you can see the catheter, the blue one, the suture, the blue one, being advanced into the Schlemm canal. So when it reached here, the surgeon will now pull the device out, tearing the trabecular meshwork and creating a communication between the anterior chamber and the Schlemm canal. So the next one is the visco 360 canaloplasty. It also is similar to trab 360. The only difference, trab 360 just means trabeculotomy 360. Now, the visco 360 canaloplasty involves similar device, as you can see, with sharp edge, which is used to make an incision into the phlegm canal. And the catheter is advanced through the Schlemm canal, through the tip of this device into the Schlemm canal, round up to 360. And then as the surgeon now begins to withdraw this catheter, he will be injecting viscoelastic into the Schlemm canal, and some of them will find their way into the collecting duct, thereby increasing the patency and ensuring that the patency of the phlegm canal and the collecting duct is reestablished. And this will eventually aid aqueous drainage. So this is a better picture of what I was trying to explain. This is the catheter or the tube that is being used. You can see it has reached this end. Then as it's being withdrawn, it's injecting viscoelastic into the phlegm canal. And some of them are going into the collecting duct. So now there is what we call the Omni system. The Omni system is a combination of trab 360 and visco 360. So the surgeon, first of all, performs a viscodilation, like in form of visco 360. And after then, he will now reintroduce the same device, into the phlegm canal, and this one into the phlegm canal, and advance it through for up to 180, and then subsequently withdraw to tear the trabecular meshwork. So it's a combination of trab 360 and visco canaloplasty, like you can see here. So that's what Omni system does.
Okay, sorry to interrupt you, Dr. Ugo. We've used 30 minutes now.
Oh, okay, fine.
30, yes.
Thank you. So this is the study that was done to assess the visco canaloplasty, the clinical outcome in 106 eyes, as you can see here. But I would like to state that there was a significant reduction, up to 20% reduction in IOP from baseline in 87% of the eyes. So the final one, okay, so the ab internal canaloplasty is also one of the things that are done, and it involves making an incision through the anterior chamber into the Schlemm canal, and the catheter is passed into the Schlemm canal, and visco is injected into the Schlemm canal as the catheter is being withdrawn. So the second group is those that increase uveoscleral outflow through the suprachoroidal space. So for these ones, you have the ones that, so it's not entirely true that all Migs are ab internal approach. Most of them are ab internal. However, there are just a few that are ab external, and those few ones are the star flow glaucoma shunt and the gold micro shunt. Now, CyPass is mentioned only to be discarded because it's been withdrawn from the market due to significant decrease in endothelial cell count in those that have undergone the surgery compared to those who did only cataract surgery alone. So in this ab internal group, we'll be talking about the iStent Supra. So this is the CyPass micro stent implanted such that one end is in the anterior chamber and the other end is in the suprachoroidal space. And this is a picture of the end in the anterior chamber, the inlet. So the iStent Supra, similar to CyPass in shape, as you can see in the device, in the picture here, this end is the inlet and is left in the anterior chamber, while the other end is anchored into the suprachoroidal space. It's injected with the aid of a device which is preloaded with it and now injected into the suprachoroidal space. That's how small it looks when you are looking at it with a finger, when you put it on the finger. So in the study, 42 eyes with advanced open angle glaucoma, which were followed for 12 months, they were followed up for 12 months after iStent Supra implantation. And there was their mean pre-op IOP was 20.4, and they were on 2 medications. All patients were treated post-operatively with topical travoprost. So 98% of the eyes met the primary endpoint of greater than 20% reduction in IOP, with a reduction of 1 medication post-operatively. So, and then the 90% of the eyes also met the secondary outpoint of less than 15 millimeters of mercury and reduction of 1 medication. There was no complication that was observed 1 year post-op. So this is the ones that are done through the ab external approach, the gold micro shunt. Is only approved in Canada and EU. It's not approved in the US. And as you can see there, it's actually a 2-leaf device that is inserted into the suprachoroidal space. And this end is the inlet that is left in the AC. If you look here, you'll see the one that is left in the AC, through which aqueous pass through into the suprachoroidal space and exits through these tiny pores into the suprachoroidal space for subsequent absorption. So in this group, there was a success. The success was defined for gold micro shunt in a study that was done to assess its efficacy as IOP greater than 5 millimeters of mercury and less than 20 millimeters of mercury, with a reduction of IOP of at least 20% below preoperative IOP. And the success rate after 5 years were 70.8% and was 77.8. Sorry, 77.8%, yes. So the final one in this group is the star flow micro shunt, which is similar to Gold Express, but not that common. So move on to the third group, which is aqueous shunt through the subconjunctival space. The examples in this group are the Zen implant and the Infocus micro shunt. So this is how Zen implants look like, and it has a device which is preloaded with, in which it's loaded and is injected into through the anterior chamber to the subconjunctival space under the tenon, so that it can form a bleb and be absorbed into the surrounding vessels. So it's actually a flexible synthetic material, and you can actually use intraoperative mitomycin. It can be done with after the subconjunctival space has been treated with intraoperative mitomycin C to prevent scar formation, since bleb formation usually occur. So this is actually the details of the technique. Time will not permit us to go into how it is done. So, but when they combined, they tried to do a retrospective study to combine doing Zen alone and Zen with cataract surgery, and there was no statistical difference between Zen alone and Zen with combined with cataract surgery. Okay, so this is the in-focus microshunt, similar to Zen. As you can see, it started through the anterior chamber to the subconjunctival space under the subtenon. So it also forms bleb, similar to Zen microshunt. So the fourth group is the group that involves decreased aqueous production, that decreases aqueous production, and that's the endocyclophotocoagulation. So this involves making an incision into the, passing a probe into the anterior chamber and targeting the ciliary body directly. So in the end, it damages the ciliary body and reduces aqueous production, thereby lowering the intraocular pressure. So this can also be combined with phaco, and however, there was no okay, so they did phaco alone and phaco with endocyclophotocoagulation. The phaco endocyclophotocoagulation group went from pre-op IOP of 19.08 plus or minus 4.14 to 1.53 plus or minus 0. Okay, sorry, on 1.53 plus or minus 0.89 medications to post-op IOP of 15.73 plus or minus 3.0 and 0.65 plus or minus 0.95 medication. So the phaco alone group showed no sustained IOP reduction or decrease in medication burden, unlike the phaco with endocyclophotocoagulation. And they reported no serious complication in either group. And the rates of cystoid macular edema was the same in both of them. So endocyclophotocoagulation compares favorably with other glaucoma surgery and has an equivalent success rate as Ahmed valves with fewer complications. So the complication, what are the complications of Migs? The complications are mainly, well, it all depends on the type of the Migs that is being done. So, but generally, you have to talk about both the complications of cataract surgery alongside the complication of some of the various Migs, depending on the one that is done. So hyphema, as we know, is commoner with GAT, hypotony, which rarely actually occurs, stent displacement for the stents or malposition, and the stents could also be obstructed or migrate to another location. There could also be fragmentation, especially for the long devices. Then there's also conjunctival gaping and peripheral anterior synechia. So in some of them might actually experience a transient intraocular pressure elevation, post-operative inflammation, retinal detachment, choroidal detachment, cystoid macular edema, IOL dislocation, subluxation, and posterior capsular opacity. So these are my references. Thank you very much for listening.
Thank you very much, Dr. Ugo. It was interesting, and it really went down to the nitty-gritty. And you were right on time too. So we spent 42 minutes.
Okay.
I can see some things dropping in the chat box already.